So start. Okay, so welcome everyone. Today we have a short online visit from YD Sapkota from Nepal. He will give us two short presentations, and we will have two Q&A sessions afterwards. The presentations that we'll have today are, the first one is about the current eye care situation in the Southeast Asia region. And the second one is about the implementation of integrated people-centered eye care, also in the same region. I will be leading the technical part, the timing part, but I will give floor to Anil to present YD a bit more, and then we'll have the presentations themselves. Okay, Anil.
Thank you, Lilia, and welcome everybody in this session. So I have given a role to introduce YD Sapkota. Most of the people already know him, but to say that he started his ophthalmic career since 1980s, beginning of the 80s. So it's almost 4 decades he is in the eye care. So he started with an ophthalmic assistant background with the educations. He's also a clinical person in that way. And he started working in the Himalayan Eye Hospital with looking after the Karnali programs. Later, he went for further studies and he did his graduations from London in the community ophthalmology. Okay. And then he led the Himalayan Eye Hospital team as an administrator. So where he also sharpened his management skill. And during the work, again, he went for 1 year to pursue further educations, that is in the health economics and bit of public health in Germany, Heidelberg, Germany. And now he's working as a IAPB Southeast Asia coordinator. And this is the third presentations, and he's basically from 4 decades working in the eye care. Okay, YD Sapkota, sir. Now the floor is yours for your presentation.
Yeah, thanks, Anil, for a nice presentation. In fact, yeah, my association with the initially Foundation Eye Care Himalaya and then with the Eye Care Foundation is long indeed. Yeah, initially when I was working as an ophthalmic assistant, and then that time Foundation Eye Care Himalaya used to do a lot of eye camps in Nepal, Nepal's in the rural areas, and initially I joined them with the as an ophthalmic assistant and helping the Dutch doctors to perform the surgeries in a rural area. And later I was kind of promoted to the camp, kind of a manager, the eye camp manager, outreach coordinator, and still the job is same, clinical, and then managing the eye camps. Since then, there are many doctors and nurses, the team used to come at that time for the eye camps in Nepal, and then yeah, I had many good friends, ophthalmologists, nurses, and then of course the eye care management and board members used to come, and then yeah, later, yeah, as Anil mentioned, that they wanted to upgrade my skill and kind of promote with giving some more exposure, and then I was sent to the London for the kind of to study on community eye health, and then after, yeah, I joined the then the concept of the Himalaya Hospital came, and then I'm just work in the Himalaya hospitals, and later also I did with the support from the Eye Care Foundation. I did the masters in public health from the Germany, as is the Anil mentioned. Since then, I also started supporting to the not only the Eye Care Foundation work, but the national program. I was involved with the NNGS, so I become the kind of the head of the research and monitoring department of the NNGS, which look after the many more hospitals than the Himalaya Hospital. It's a bit broadened my work. And then after working long time in NNGS in the National Eye Care Program, and then I joined the IAPB in 2014. My scope of work is more broadened now, is Southeast Asia, with all the experience gained with the eye care teams in the Eye Care Himalaya. So in brief, in nutshells, in fact, I am made by the iCare Foundation. I am the person made by the iCare Foundation, or the Foundation iCare Himalaya. So yeah, I work with them, and then that's the opportunity I got all, and then I became now at this position. We are kind of the becoming the coordinator for South Asia, and then kind of the regional planning advisor for the many of the countries. And then I'm also the WHO certified blindness survey trainer. So to become a trainers, and then I'm the two of the South Asian people, one of the two South Asian people who is certified to carry out the blindness survey in Southeast Asia. So many of the South Asian countries, blindness survey is done by me, or supported by me, at least other trained by me. The survey team are trained by me, like in Nepal, Bhutan, Myanmar, Sri Lanka, Timor-Leste, all these countries blindness survey was I supported them. So become the kind of the regional person now at the moment. So now the presentation, today's presentation also, with discussion with the Anil, I have made two parts of the presentation. First part, I will present you what is the problem, the issues, and the magnitude of the problem in South Asia, Southeast Asia, the iCare vision impairment problem. How big is the problem? That I will show you. And then the second part, I will relate. I would like to relate this first, the issue. The first part is the issue, and then a bit of the discussion if there are questions. And then the second part will be the integrated people-centered eye care. Now is after Vision 2020, the global eye health strategy has been changed. Of course, the Vision 2020 ended, and then the blindness and visual impairment not ended, of course, and our aspiration to work against the blindness has also not been ended. So therefore, we have to have another strategy to come and to follow all the eye health stakeholders in the regions. So the IAPB has a 2030 insight. That is our sectoral strategy. I understand that has been presented by one of my colleagues, Drew, in the last month. So I'm not going much into that part. But what I want to today want to share with you, the WHO has launched the integrated people-centered eye care. So the first part will be the kind of identifying the issue. The second part will be how does the IPEC strategy works to tackle those issues. That is the things I would like to share with you. Since I'm Anil mentioned, I'm a clinical person by basic. Some of my things could be a bit clinical also. So please stop me and ask if anything is not clear, not clear to you, if you are not clinical persons. But I will try to make it it's more clear or more simple as it possible. So now, can I share my screen?
Yes, you are already host. Now you can share.
Thanks. I think it will work this way. Sure.
Yes.
Can you see my screen now?
Yeah. Okay.
I can see. Where is the presentation?
So in the meantime, basically, you are responsible for Bangladesh, Bhutan, India, Indonesia, North Korea, Maldives, Myanmar, Nepal, Sri Lanka, Thailand, listed more, right? These are the 11 countries. Okay.
There are 11 countries in Southeast Asia, and then there is not much going on in DPR Korea. They don't like them called to be North Korea. They say they should be called as DPR. Because they are the most democratic country in the world, they think. Therefore, Democratic People's Republic of the Korea. DPR Korea is not much, but other 10 countries are very much involved. So before we go to now can you see my screen now? Yeah, presentation is there, Anil?
Yes.
Okay, good. So maybe some global, just to start with the global things. Now is the mantra of every eye care stakeholder in the globally. once the World Report on Vision published the global scenario of the data in 2019, according to the World Report on WHO World Report on Vision, they says that there are 2.2 billion people are vision impaired globally. Out of them, 50% of them, 1 billion people still do not have access to the eye care. And then if we don't do much more than what we are doing, accelerate our work, if something is not changed drastically, that this will reach to the 1.8 billion people without eye care access by 2050. That is the estimation they made in the World Report on Vision. That is the global scenario. We know, I think you already know all this. And then the South Asia region. South Asia region is a more of the region we are having the more of the people and then more of the blind people compared to the other region also. The South Asia region is a kind of the 51% of the world's populations, but account for the 62% of the estimated 216.6 million people in the world with a moderate and severe distance visual impairment. So this is the globally, we have a 50% of population, but a 62% of the distance visual impairment that resides in the South Asia. And then it is divided in the South Asia is a kind of 61 million, 61.2, East Asia is including China, 52.9 million, and Southeast Asian, the Pacific Rim is 20.8 million. That is what it divided. If we see that in the millions people with a visual impairment in the graph also, the South Asia is the tallest one. Southeast Asia and the South Asia, where the people with do not have access to the people is also a bit wider than the compared to the high income and then the other countries. You see, the South Asia has a more blindness and visual impairment problem compared to the other continent. This is for the distance vision impairment. If you look at for the simple glasses, which is the we call it a near vision. It's a near vision impairment with this simple pair of the glasses could resolve the issue. We see that in a high income country, we see that almost everyone has that kind of reading glass who need it. You see in the left side is a high income. And then if you see in the South Asia, see there is a more in the Southeast Asia and the South Asia, even with the people who have the glasses in the Southeast Asia, 50% do not have, and then in the South Asia is 70% of the total 400 million people with the fresh myopia do not have even the simple pair of the glasses, do not have the access. That has made this issues more problematic in the Southeast Asia. And then if you see the kind of blindness and visual impairment prevalence of the blindness in the South Asian countries, so the more blindness, there are more data. Sorry for this, the too many information in it, but I just want to see in the third column, if you see the blindness, skewed blindness in percentage, I think you see that there is Indonesia and the Myanmar are the highest ones. This is the all age prevalence in the all age. Nepal has reduced significantly. It used to be 0.84 in 1981 and has come down to the 0.35 now, almost 0.3. But there are the countries like India, Bangladesh, Indonesia, Myanmar with the high prevalence of the blindness. And then if you see the inequity among the gender also, that's what I want to show in this slide. There are significant inequity in the proportion of the female. There are more female are blind than compared to the males. So the service accessibility of the female is the big gender is the big issue in our part of the world. If you have any question later, I can answer it. Yeah, and then similarly in the childhood blindness, if you look at those are the adult blindness prevalence, and that they say the childhood blindness also is one of the highest in this area. this is the childhood blindness is usually related with the under 5 mortality rate. If the under 5 mortality rate is high, that means the childhood care in that country, healthcare is not good. That also very much related to the towards the blindness. So if you see the Bangladesh, Bangladesh is the one of the highest one. The prevalence of the blindness is a 6 per 10,000. And then the Nepal comes to the also the Nepal, Myanmar, and the India comes to the 5. Timor-Leste also 5, and then the other country is a 3 to 4 per 10,000 prevalence of the blindness in our region. The estimated number of blind is just extrapolated to the populations. So of course, the India is the highest one. India and Indonesia are the highest one where the childhood blindness, blind child, more blind child are there. And then if you look at the human resource in the Southeast Asian countries, when you talk about the human resource cadre, we mainly talk about the 3 categories: technical and the clinical people, ophthalmologist, optometrist, and allied ophthalmic personnel. Allied ophthalmic personnel include the ophthalmic assistant and then the ophthalmic nurses also. So according to in the ophthalmology situation, it looks like the India is the very good ones. It has a one ophthalmologist is to 60,000 populations, and then the best one is the Maldives, of course. The one ophthalmologist is to 12,000 population. It is a small country. The healthcare expenditure of the Maldives is almost more than 10% of the GDP. So GDP, therefore they have a very good health system and insurance system, and then the more of the ophthalmologists are there also in Maldives. But when you take out the Maldives, you see the almost all the countries will have one ophthalmologist is to 100,000 populations. In the WHO recommendations in a Vision 2020, it was already in Vision 2020 report, was should have been a 50,000 population for ophthalmologists. One ophthalmologist is to 50,000. In the high income country like Western Europe and the US and Australia, it is even better than the WHO recommendations. But in the South Asian country, you see in the Timor-Leste is only 3 ophthalmologists per million population. That means one ophthalmologist will have to look after more than 300,000 populations. And similarly, the Myanmar also has an issue, 152,000 population is to one ophthalmologist. This is just simple the numbers, but the distribution is another big issue, because the most of the ophthalmologists, optometrists, they are more concentrated in the city and big cities and then the urban areas, and the rural area are more deprived. Similar situation also in the optometrist and the allied ophthalmic personnel. The similar of the situation, it is far less than what the WHO has recommended, but the Nepal is in the middle. In all of the country, in the Nepal is in the middle of the situations in the human resource also. And then when we look at the surgical coverage, the service they provide, the surgical coverage, this is a bit technical term, is a cataract surgical coverage. And then now WHO has introduced the new indicator, which we call it effective cataract surgical coverage. So hope you understand these terms. Cataract surgical coverage is the total number of the people requiring cataract surgery. Out of them who receive the service is the coverage, cataract surgical coverage. That the visual acuity cutoff is a 618, that is the visual impairment. Now, the new indicator says that ECSC, that means effective cataract surgical coverage. That means total number of people requiring cataract surgery, and then after that intervention, out of that, the people receive the surgery and the outcome is good, with a good outcome. That means that includes the quality also. That includes the quality also, because all the cataract surgery on people who have undergone is not visual outcome is as not good as it should have been, because of the surgical complications and then other problems, the quality of the services problems. So the new indicator ECSC, that includes the quality also. So in Bangladesh, is a bit older data. We don't have a new data, so no need to discuss that one. The Bhutan is the one of the latest data, which we did the survey, and then the cataract surgical coverage in the Bhutan is a 57.5%. But if you include the quality, the people who have undergone the cataract surgery has a good outcome, then is only 42% of them has had cataract surgical coverage. The India is the most, one of the highest one. India and Nepal is the highest one for that region. The India has a cataract surgical coverage is a 73%, and with a good outcome is still 55%. It's a good ones. Indonesia is one of the lowest. Is a cataract surgical coverage is very low. Only 26% of the people having cataract with the visual impairment has had a access to the services. And then if you include the quality, that goes to the 19%, below 20%. And then Maldives is another good one, is almost 70% have has cataract surgery. And then we include the good outcome, it is a kind of the 52%. So Nepal is the most recent data we have had, and we recently completed the survey. Still the data is yet to be disseminated. We have a cataract surgical coverage also almost 70%. Out of those who need the surgery, at least the 70% have had a cataract surgery. And then if you include the outcome, it goes to the 58%. The quality is still a bit of the issue in some area. And then similarly, same as this Indonesia, the Timor-Leste has another issue. Cataract surgical coverage is very low, 22%. And then the ECAC is if we include the quality, if it's only 15% of the people who needed cataract surgery has undergone surgery with good outcomes. So these are the kind of the scenario I showed in the South Asian countries that we have a big magnitude of the problems in Southeast Asia, visual impairment problems. And then there are human resource also the issue. And then the service coverage is also the issue. And then the quality is also the issue in this part of the world. As I mentioned, we have recently completed the National RAP survey and consolidated report. Just a glance I will like to present, is not yet disseminated. When you look at the Nepal more closely, more deeper dive, we have 7 provinces here. 7 provinces, and then the Eye Care Foundation works in the province 1, and then the province, like the Gandaki province previously was a province 4. Of course, it supports the National Eye Care Program also, but the 2 hospitals has been directly supported by the Eye Care Foundations. In the province 1, the prevalence of the blindness in the male is 0.94, in the female is 0.94, and the male is 0.78, and overall is 0.96 in age 50+ people. It is not very high. It is reasonable. There are in the Madhya Pradesh, in the Tarai area is 1.25. You see, the Bagmati is the better one. The Bagmati is the Kathmandu, where we have most eye care services, and the 60% of the ophthalmologist is working here. So the lowest prevalence. And the Gandaki is a similar, same as the Mechi, is 0.95%. Let's look at the last column. The Lumini is the highest one in the prevalence of the blindness. And then the Sudur is the far west, is the one, another best one eye care service, where the Dhangadi we call it. Then there are somehow the prevalence of the blindness found to be lower. Overall, Nepal 50+ population. 1% of the 50+ populations are still found to be the blind. And when you compare, the Lumini province is the most worst one. And similarly, when we look at the first column, first row is the blindness and the severe visual impairment. Also the similar situations. We have a 1.1% of the blindness, 1.67% or close to 2% are the severe visual impairment according to WHO definitions, and the moderate visual impairment 7%, and the mild visual impairment is at 10%. Overall, in total there are among the 50+ population, 20% of the people are having some degree of the visual distance visual impairment. So that's the whom the service is required. And when you look at the cause of the Nepal blindness survey that has recently been done, and among the first column is the blindness category. Of course, the cataract is the highest one still, and then the corneal opacity is the second highest one still. This trachoma is considered as eliminated. There are not much, though the old corneal scar has been found now, but there is no active trachoma anymore in Nepal. Is eliminated, but the other corneal opacity is a significant problem. The other corneal opacity usually happens due to injury, trauma and injury, and then most of the people, agriculture, industrial people, and the road traffic accident, or some kind of injury due to corneal injury, corneal opacity happens. That is still is a second, now is become second highest. And another always underdiagnosed cause is a glaucoma. Glaucoma is not easy to treat as a cataract. It requires more sophisticated equipment and technology to diagnose, and then long-term treatment is required, and the surgery required. So the identification is the issue, and the treatment is also issue. And another issue is among the blindness is a age-related macular degenerations. Usually, it is a problem of the elderly people. There is no effective treatment available. This is the one with the major cause of the blindness in the high-income country, because of the effective intervention is not available. Cataract and other problem is solved, but this is still considered as an incurable cause, and then therefore there is a major cause, but it is also coming up in our part of the world. In the severe visual impairment, a similar situation. In the moderate also, the cataract is still leading. But in the category of the mild visual impairment, is a refractive error is leading. Refractive error is the people with the visual impairment who need the glasses, pair of the glasses. That is the major cause of the visual impairment. That means the major focus still in our part of the world is in the vision impairment category is a refractive error, and then in the blindness category and the severe visual impairment category is the cataract. So those are the major cause of the blindness. So these are the problems data I presented now. I will stop here, and then maybe we can have some kind of the discussion, and then before we go to the integrated people-centered eye care, if you have any question, please now we'll come up to the question and answer session.
Thank you very much, YD. I just wanted to say that we have 5 minutes for the questions this time, and then after the second presentation, we'll have another 5 or 10.
Okay, great. Thanks.
I have one. Thank you for your presentation. I have one question. I saw in one of your pictures that as for Indonesia and Timor, there are no data at all since 2016?
No, Margaret. In fact, we consider 2016 data is still, we call it the kind of the fresh information for the blindness, because the blindness and national blindness survey usually is done in if it's an ideal situation in every 5 years, but it doesn't happen every 5 years. It takes 7 to 10 years for every country to do the blindness survey. The Nepal is the one of the lucky one in that sense. We have a regular blindness survey is happening, but many country of our region, the blindness survey is have a bigger interval. So therefore, the 2016 data, Margaret, we still consider as a fresh data since other data is not available. Thanks.
Okay, thank you.
Yeah, beyond there, you have something?
Yeah. Sorry. Okay. YD. Yes. I saw there was in the Thailand. I'm surprised that you have no data for optometrists. Don't they have a optometrist in Thailand?
No, yeah, it's true. There is no optometrist in Thailand. The human resources is another big issue in our part of the world. In some country, in some of the country in the region, there is optometrist work is not recognized at all. And then some countries do not want the optometrist to have a that cadre. Yeah, in the Thailand there is no optometrist, and but to answer you, it's a big political issue. We can discuss in a different session.
YD. Okay, Bjorn, you first.
You showed this slide with optometrists and optometrists, how many there are and in percentage. How many do we come short? So it's not only on the quality, of course, because you also talked about it, it's also about quality, but in numbers, how many do we come short?
Yeah, according to the WHO, that's I haven't showed that. Only the population ratio showed the WHO recommendations. The recommendation in a Vision 2020 report is the ideal situation for Asian countries is a 1:1 ophthalmologist is to 50,000 populations of the ophthalmologists, and same for the optometrists, and the 25,000 for the allied ophthalmic personnel. That's the WHO recommendation. We are still fall short. Nepal is almost reaching on that. Nepal is a one ophthalmologist is to 70,000 populations. I think, but it's almost reaching to that. But many other countries fall short. And then another big issue is I mentioned that the distribution. The more are in the major city, not in the rural areas.
And if you say that 1 out of 50,000, that means that worldwide we come to many ophthalmologists which are needed, but how many do you in your region come short, sort of?
Yeah, there is a globally in the East region has a different recommendation. The Africa region has a the WHO recommendation is a 1:100,000 Peter John, because it's a far short of the ophthalmologists in Africa compared to the Asian countries.
Yeah.
So the Asian country is at 50,000. Many are approaching there. I haven't calculated as per population ratio, but I have shown the population ratio. Only the Maldives has achieved that target, but remaining all countries hasn't achieved. The India is very near, is a 62,000 populations.
Yeah.
1:62,000. Nepal is 70,000. Other countries are still 1:100,000. So they need to be almost doubled the existing number of ophthalmologists by 2030 to achieve this WHO recommendations, John.
And if you look at your region, is there a specific country or a specific institute where most of those ophthalmologists are trained?
Yes, yes. Every country they do have a in-country training program, except 2 countries do not have. Maldives and the Timor-Leste do not have the post-graduation training option for ophthalmology. They still have to go abroad for the training. Other countries they do have a training facility, but which need to be further accelerated in terms of the number and then in terms of the quality also. That is what the need, what we focused now in the years to need to focus in the years to come. Yeah.
Okay, I think if there are no more questions, Anila, I think you wanted to say something or not anymore?
Can I ask something quickly?
Sorry, yeah.
Okay, go ahead.
Thank you for your presentation. If you're looking at all the NGOs in your region, what could ECF focus on more to help support? For example, the ophthalmology post training, or was there some area in particular you had in mind?
Yes. Thanks for the questions. Yeah, I think it's a country. It is more of the country-specific issues are there. Yeah, in some countries, the human resource is the issue. The number of the human resource is the issue. In some countries, the human resource is there. The productivity is the issue. In some productivity means the skill and the quality are the issue. And some countries, the distribution are the issue. If you look at the Indonesia, the where the prevalence of the blindness is high, cataract surgical coverage is low. And then the most of the ophthalmologists, they are focused or located or resided in the Java only. And Indonesia is the country where you have more than 20,000 islands all over the seas. So in those part of those population do not get the ophthalmologist services. Most of the ophthalmologists are the issue. And then another issue is a productivity also. Productivity, if you say if you see the Bangladesh is one of the good ones in the number of ophthalmologists, is 1:100,000 populations. And then if you compare to the Bangladesh and the Nepal, Nepal is a kind of 400 ophthalmologists. They operate almost 400,000 cataract surgery. That means including the Indian patient, I mean, the 400,000. So the productivity is that good in Nepal. Whereas in the Bangladesh, the productivity is very low. Nepal's because the another method of the measuring the productivity is a cataract surgery per million populations. The Nepal has a kind of almost 5,000 per million, 5,000 surgery per million population in an average at national level, where the Bangladesh has 2,000, where the number of ophthalmologists is much more in Bangladesh. So the productivity is another issue there. So most of the ophthalmologists in Bangladesh, they are seated doing the very basic things and primary eye care and their refraction services, don't do the cataract surgery. Those are the issues need to be tackled. So it is a countrywide issue. In some country is a governance, some country is a priority to the eye health, some country is infrastructure, eye care service accessibility, and some country is a human resource, and then in some country is a productivity of and the distribution of the human resource. Those are the issue. And then the NGOs and the IAPB, we all need to be worked. And of course, for the Indonesia and the Timor-Leste, the service accessibility and then increasing the number of beneficiaries is the big issue need to be tackled. Similarly to the Myanmar. Myanmar is a kind of governance issue and the political issue is also there. But these are the area we NGO need to work in further. I will come up a bit more on this also in my second presentation. How do we implement integrated people-centered eye care also on this? Thank you so much.
It was super interesting to hear, but you were so fast that I was writing and I know it's recorded, but just as a question to sum it up. So you said the causes could be the quality of the outcome, distribution, productivity, government, and service delivery. But what did I miss? I missed, I think, one.
I think
you missed capacity. Yeah.
Sorry?
Capacity.
Okay.
Yeah.
Super, thanks. Super interesting. Thank you so much, Andrea and YD.
Yeah.
Okay, thank you all. I think we can start with the second presentation.
Yes.
Yeah, thank you so much. I'll again go to the share screen.
So basically the second session is now this is the burden or something like that, the situations, how we mitigate or what is the way forward, right?
It's not a region specific now. It's what's the global strategy to mitigate this issue? This issue is the other part of the country, other part of the world, also Africa, and then the Pacific region also. So it is a more global presentation. So we have to adapt and translate it in our way and in our region also. So now is what is the like? Now.
Sorry, it's the end of the slide.
No, it is already the previous ones. So I have to go out of this. How to go out of this?
Escape.
Escape doesn't work. Oh yeah. Okay, now it's working. Slowly working. I'll open the other one. Yeah, this is the things. What is the in previously we have had a kind of the Vision 2020 strategy, which started in 1999 together with WHO and IAPB. In fact, those Vision 2020 era also we have a lot of improvement, achievement in the achievement in eye care sector, because the Vision 2020 has a kind of a strategy that with this citing the similar problems, that there is a big issue. This, if the issue is not tackled well, or we don't do much more than this, that the blindness will get doubled in 2020. That was estimated, but it didn't happen. It doubled. It in fact some reduction in the blindness category, so that the Vision 2020 was successful on that. Similarly, Vision 2020 is in date. Now the next strategy has come up. Next strategy, that is the integrated people-centered eye care, is the another strategy. It is in a WHO strategy, and then it was endorsed in the World Health Assembly resolution in 2020, and then also included eye health indicator in universal health coverage in 2021 World Health Assembly. So therefore, this is the strategy has been endorsed or accepted globally by the almost every country of the world to implement in the eye care strategy. So in their eye care programs. So that means we also every stakeholders, NGO and the government need to work together to deliver this integrated people-centered eye care. And so I just today's my session is just to disseminate what is actually means, what is this integrated people-centered eye care, and what we need to do differently than the what normally we are doing in this global strategy. So again, the similar slide. I think I already then. So although the Vision 2020 era is in date, we have some kind of achievement, but the challenges, many of the challenges are continued. Therefore, the new strategy need to be developed. That in the changing in demographic, we have a demographic and lifestyle, and which will increase the eye health demand, because we have a more number of the elderly people, so where the blindness and visual impairment likely to occur more. And then the lifestyles, kind of the problems like diabetic retinopathy and the hypertensive retinopathy, those lifestyle problems cause for the blindness is increasing. Therefore, our challenges is still there. And then still inadequate government prioritization for the eye health. We need to work more on that. And then still the eye care service is a vertical, fragmented, not well integrated in the overall healthcare system, is not a part and parcel of the healthcare delivery of many countries. And that there are inequities in the access, as I mentioned already also. And then the eye care service is not comprehensive. There is a more in the curative side, and then there is a promotive, preventive, and rehabilitative side that is still not well taken care of. And then it's still the workforce, eye care workforce is an issue, which I showed in my regions, and then our lack of resources. And then overall, there is also the problem, we have a problem of the data. There is no data available on the magnitude and then the impact and then the cause and association of the blindness in many countries. So for this, integrated people-centered eye care started from the publication of the World Report on Vision in 2019, in the launch in the WHO, and that recommended the strategy, core strategy of the implementation of the IPEC. It has given a kind of the framework, how the eye care service should go, and then based on that, IAPB also has developed it's a sectoral strategy, like eye care service need to be elevated, activated, and integrated. So those things came up in 2019, and then the integrated people-centered eye care also in the World Health Assembly endorsed in World Health Assembly resolution in 2020, and then is overallly endorsed, and then urges all member countries to implement it. And then in the same process in 2021, two of the indicators, because in the universal health coverage, eye health was not there in it. So finally, with a lot of effort from the IAPB and then the other stakeholders pressures, so the World Health Assembly has included that the eye health is a part of the universe, should be a part of the universal health coverage. If the eye health is not, without eye health, the healthcare cannot be universal. So that was finally been realized, and the two of the indicators has been included now in 2021 as a part of the universal health coverage. I mean, the eye health indicator was included as a part of the overall universal health coverage indicators. Similarly, another milestone achieved in 2021 in the UN, for the first time, the UN resolutions, the vision was included. So it was considered that the UN has launched the Sustainable Development Goal in 2016. In fact, it is already 5-6 years back. But in that, the health is in the SDG goal, out of the 17 goal, goal 3 is the health. In overall health, the eye health was not spelled out well. So finally, in the 2021, they have been realized that the many of the SDGs, out of the 17 SDG, 8 are directly related to the eye health. If there is no eye health system, good eye health system in the country, there is not likely to achieve the SDG goals. For example, quality educations. Quality education cannot be achieved without the good visions. So poverty alleviations. So poverty alleviation, when there is a more blindness, there is a more poverty. If you do not eradicate blindness, poverty cannot be eradicated. And the equity, genders, climate change, and the work productivity, economic performance of the people, all are related with the eye health. Therefore, finally, UN has realized that the eye health should also be included in the SDG agenda. And then the eye health is considered not only the eye, not only the health issue, it should be a part of the overall development issue of the human and the country. So finally, the UN also come up with that resolution. These are the kind of the landscape of the integrated people-centered eye care. All has concentrated on the integrated people-centered eye care. So, World Report on Vision is the framework shows that the make an eye care should be an integral part of the universal health coverage, and finally UN also endorsed it and implemented people-centered eye care so that all people who need the eye care service will have access to the eye care service. That is the ultimate goal of the IPEC, or the integrated people-centered eye care, without any financial hardship in it to achieve. So the finance shouldn't be the prohibited matter for to access the eye care services. So mainly, what is the IPEC means according to the WHO World Report on Vision. So the eye care should be a kind of the comprehensive, not only the cataract focus or the refractive error or the disease focus, which used to be in a Vision 2020. The eye care, there are disease focus activity were there, but now it has been recommended eye care should be a comprehensive. It should be a complete package of the promotive, preventive, treatment, and rehabilitative. People who do not be treated, or the prevented, the blindness could not be prevented or treated. Those should also be included in the eye care program with the rehabilitation programs. And another aspect of the IPEC is it should be coordinates all sectors. That means it's not only the tertiary level or secondary level, primary eye care should also be strengthened. And then it's not only the healthcare. It should not be the agenda of the eye health people also. It should be the health of the. It should be the agenda of the other health people and the other sector also. For example, school education sectors, Ministry of Education. I mean, the Ministry of Education should also have a eye health program so that their children's school will have a good vision. If the vision is impaired, then they should have access. And then industries, agricultural sector, I showed already, and then other occupational health hazard happening sectors also should have should be coordinated with them, and then the eye care should be a part and parcel of their work also. That should not be limited to an eye, should go to the overall health and then the beyond the health. And then the eye care, we are mainly talking about the visual impairment and the blindness. And then it should not be limited on the vision impairment and the blindness also. There are many eye diseases which immediately doesn't do the blind or the vision impaired, but a lot of discomfort will give, like for example, dry eye, blepharitis, cyst eye, conjunctivitis. All those things also should be considered as taken as a priority, not only the blindness and visual impairment. And then should have a eye care service, should have a all the people's need throughout the life course, means that there should be a provision for the pediatric or neonatal eye care. There should be a provision for children's eye care, and then also for the geriatric eye care. All should be there. That's what we call it the integrated people-centered eye care. Should be a comprehensive, should be coordinated all sector, not only the health sector, beyond health sector, and should address all problems of the throughout the life course, and then should be according to the need of the people, not only the need of the data showed for the blindness and visual impairment. That's what the integrated people-centered eye care means. So integrated people-centered eye care approach is needed, which is the issues is identified in World Report on Vision. So that is the issue is equity in access. So there is a gender equity, there is a rural area people do not have access, and the deprived, marginalized, certain ethnicity, ethnic group do not have proper access. So kind of the equity should be there. So another issue is a quality. As I showed the data, comparing the cataract surgical coverage and effective cataract surgical coverage, there was a big difference in the coverage. That means the quality is the issue in eye care services. And then another issue is a quality monitoring mechanism in place. Also is the issue of those are the data and the informations are the issue. And then the responsiveness and the participation, and the people should make a kind of the activate or the sensitize where they can demand for the eye care services. So they can express their need of the eye care services, and then they're allowed to participate in eye health, including community participation, means including their leadership, their governance, and they can also contribute financially. Those things should be considered. And then the other thing is eye care should be a kind of the resilience in case of something hazardous comes, like a COVID period. COVID happens recently. The eye care should be prepared for those kind of the crisis, and should be a resilience, and the people, the skills and the capacity should be strengthened on that way. And then the eye care should be cost efficient, and another is the efficiency. Service provided is the most cost effective setting with the right balance between health promotion, prevention, treatment, and rehabilitations with the appropriate technology in place. Those are the approach we need to work on further in the future, in the future eye care services. And for that, just for your information, so we have a WHO eye care in a health system. The WHO has come up with the many tools now. Recently been also launched the recent World Health Assembly in last month in May. Also, WHO has launched many tools to make the eye care service more effective. Those are the most important one is the guide for actions on integrated people-centered eye care. This book gives us the detailed information, and then the more practical framework how to implement integrated people-centered eye care at the national level eye care services. And similarly, basically this guide for action says that you have to analyze the situation analysis of the problem, and then you have to plan and do the things and review what you have done. Those are the basic four stages is the guide for action gives us. This will makes the IPEC more effective if we use this tool in our country. And similarly, there are other tools also WHO has published. That is the EXACT. Another is the eye care situation analysis tool. That is the tool we need for the situation analysis. And the package of eye care intervention. This tools gives us the more detailed informations on the what level of the services need to be done in the community level, and then what level in a village or the primary eye care, and the secondary, tertiary, secondary center of excellence, what level of services, and then how it can be implemented. Those tools will give us this information. And then similarly, there are when planning this eye care indicator menu, the WHO has identified 13 core indicator in the eye health services. Eye health services should have at least this 13 core indicator for monitoring their services. And then the 13 additional indicator has also been given. Those as an optional. Those can also be added in all the eye care interventions. And then also has published another book as an eye care competency framework. That means what level of the competency of the eye care task force workforce should have. What level of the people should be appointed, what skill and knowledge is required at community level, and what the ophthalmic assistant need to do, and then what level of training and then the skill they need to learn. And similarly for the optometrist and ophthalmologist, there is an eye care workforce competency framework is also been published. So basically these WHO tools also help us to planning the eye care services, and then to implement the integrated people-centered eye care. And then I think each tool has a very detailed information, and then this tool will be helpful for us in the translating integrated people-centered eye care, and then our addressing the issues which I have identified in the previous presentations. So if there is any questions there in these things, that's what I wanted to share you with, just to give a kind of the glance how the global strategy of the future eye care program, and then how it can be, what it suggests, and then how we translate. So our future eye care program should go to in basis of what the WHO has suggested, like in the Vision 2020 strategy. Now our strategy should also guide with it, with all this, our national or the community level strategies should also guide with this. Now the global WHO global strategy, which has been endorsed by almost all countries in the world. Thanks.
Thank you very much. I just wanted to mention that since we started a bit later, we will finish a bit later, but we still have 6 minutes, I think, for the questions for this presentation.
Thank you. Can I ask one question, YD sir?
Yeah, please.
I saw it in the second part that IPEC,
Yeah.
You know eye care foundations more than us, because you are from the beginning, 40 years back, you are associated with eye care. We are a learning organization, we are a growing organizations. How it will be feasible to go in the rehabilitations part to cover the IPEC? Rehabilitation is another part. So for a small organization.
Yeah, that's what is the main issue. Is that many of the eye care service providers or eye care service supporters, or even the government, the more focus now goes to the curable blindness, mainly to the cataract and refractive error, which is cost-effective intervention and easy intervention. Also, rehabilitation part is not well taken care of. And then in this eye care, in the package of the eye care intervention, if you look at on that book, it is more information you will find on that. So the people who are the basic concept is the people who cannot be cured with the medical, optical, or surgical intervention, and if it is a physically fit, so it should not be left behind. So it should also come, and it should also be a part of the social mainstream social organizations. So they can do many more things. Even they have a visually disabled. Of course, they have a many other capacity to work. So they should also be included. Those people, and then many of the people. I think many of the problems we call it low vision problems. People are having the low vision, which could optimize their vision with the assistive devices and then other technology. and improve. And then many blind children who doesn't have access to the blind schools, Braille school, learning by Braille. Those things should also be should include eye care service, should include this. Those should not be left behind. That is the motto, and the detail you can find in the package of eye care intervention.
So what I also mean is it will be not cost effective for a small organization if you focus on the rehabilitation part by ourselves. Maybe a low vision could be done in hospital, but
every organization are the resource limited resources. Of course, they will have to work according to the resources they do have. You cannot do everything at once, of course, but you should start with something. If you have something, what your capacity allow you to do, should do something. But your program, but you shouldn't do that. You are incurable blind, so not in our vision. So that should not be the agenda. That's the main thing. They should also advise. Only the advice to go to where they can learn, where they can find the service, or where they can find the rehabilitation service, or the social inclusion, where they can find the access to the social inclusion. Only advice could be a kind of the initial step, but the overall comprehensive, making everything available at once, will not happen in any country, I think, any place.
Okay, thank you.
Anyone else? Bjorn.
Yeah, Bjorn.
If I would be able to combine the two presentations you gave, and if you take in consideration that in your area also many of our colleague NGOs are active, and you know all of them, and what they do, including us. I see many times education coming by, either educate more colleagues to help, or we help people in education, like school children. So education I see all the time. But is there anything you would advise us, including all the other NGOs, maybe to work together on, to improve something quicker than, or rapidly, or more efficient than how it's going now? Because you have this overview, and maybe you see us NGOs doing something which you like us to improve by working together.
Yeah, very, very good question, and Bjorn. I think there is an issue where the many of the NGOs are working, kind of the collaborations and the coordinations is of the big issue, and then kind of the competition is there, which is not necessary. The collaborative effort could have been the better way to resolve all this issue. That is therefore what we have been suggested in the old report on vision is that there is a collaborative effort is required. All the stakeholder, that there is a system change strategy is there, where the stakeholder is stakeholder analysis and collaboration among the stakeholders is a very important part, where they can raise a bigger voice also to do the advocacy with the government, where the eye care is not prioritized. The collaborative effort, that is the most important things also is been highlighted. Therefore, what I would suggest also, there should be a kind of the NGO forums in eye health services in every country, and which will be supporting to the National Blindness Committee, which is owned by the government. So that's what the IAPB is also trying to work on every country. So so that among the NGOs, non-government sector, many countries, the most of the service delivery part is been very efficiently done by the NGOs, but their work are also not been recognized, and then not coordinated, collaborated. That is also the big issue. So that should be some kind of the strategy we should have in the national. So the supporting the National Blindness Committee and the supporting the national strategy that will bring all the NGO together. If every country, if we help the country to develop the national target and then the national goal, and that way, I think all the people, all the stakeholder, the stakeholder working in that country will come in more collaborative way. That's what we are aiming to do in the years to come.
Okay, thank you. I think if there are no more questions, we can wrap it up. If everybody agrees, yeah,
Okay.
I wanted to thank YD for the 2 very interesting presentations. Anil for helping to supervise the meeting, and for everyone for joining. Yes, thank you all.
Okay, backside of the YD is what you can see the mountain from our hospital, the Himalayan Eye Hospital. The same pictures, you can just take it. It will be. So there is the hospital.
This picture was taken from the near the Himalaya hospital.
Yes.
By me, by mobile phone.
This simple mobile, you can just have that.
Yeah.
Mountain.
This is the picture I took, Anil, when we are there in the World Sight Day. No?
Oh yeah. Yes, I remember now.
Yeah.
Yes. Okay. Thank you so much, everybody.
So Job, this is what you will see.
Yeah. Yeah.
Beautiful.
Yes.
Thank
If
you,
there are
YD.
no
It was super
doubts.
interesting. And is it possible for us maybe to examine the PowerPoints later also?
Sure. Of course.
Yeah. Oh, thank you so much.
Okay, thank you. See you next time.
Yes.
Thank you very
Bye.
much.
Thank you. Thank
Thank
you.
you.
Thank you, Dai.
Thanks. Bye.
Bye-bye.